you. Thank you for this opportunity. And today's topic is actually approach to HIV. So at the outset, I must confess that probably I won't be able to cover every aspect of HIV, but definitely in over next one hour or so, I will cover few of the epidemiology and the overview of HIV, pathogenesis of it, clinical staging, diagnosis, antiretroviral therapy and the treatment approach, the basic approach, and few cases that needed intensive care admission. I'll cover few cases on CNS syndromes, respiratory syndromes, and one case on GI syndrome. And at the end, take-home message. So this is a summary of global HIV epidemic 2021 data. As you can see, 38.4 million total cases is the prevalence, and the new cases were 1.5 million. And people dying with HIV in 2021 was 650,000 around. So this is the amount of burden that HIV is giving globally. So with this, I'll just go to the question for the students. What do you think? What is the adult HIV prevalence rate in India? This is very important to know because whatever be the prevalence, the population in India is so high that creates a lot of patient load to the HIV global load. So if you can answer, I'll wait for a few seconds and then I'll move on. You can answer in the chat box. What is the adult HIV prevalence rate in India? Is it less than 1%, 1 to 5%, 5 to 10, or 10%? Okay, few people are answering already. Fine. So this is the picture you can see. India comes in the less than 1 bar. So less than 1% bar, that is actually the prevalence is 0.2%. Every 1,000 patients, 2 patients will be having HIV in India. So the burden actually looks low in number, but as the population is very high, the amount of burden, as you can see here. Yeah. So this is the statistics. 2.4 million people in HIV with HIV in India, and this is again 2021 data, and 63,000 new HIV infections and 42,000 were the HIV related deaths. And now India has set a goal of 95 targets from 1990, which means that 95% of people will know their HIV status. Of those who know their HIV status, 95% of them will be getting the ART, and of those who are getting ART, 95% of those will be virologically suppressed. As of now, 77% of the people know their status, 84% were on treatment, and 85% of them are suppressed. So it becomes 65% of the people only with HIV having the ART. So it's a big chunk of people who are not getting ART. So there is still a possibility of getting patients with opportunistic infections, bad infections in a critical care with HIV. So how it is transmitted? Which of the following carries the lowest risk of HIV transmission? What do you think? Is it a receptive anal intercourse, or is it a receptive penovaginal intercourse, or percutaneous, or infected blood transfusion? So please answer in chat box. The lowest risk of HIV transmission among the following. Okay, so most are giving answer for 3 or C, but the lowest risk is probably receptive penovaginal intercourse, and percutaneous there is a considerable risk. So always we give PrEP in a significant puncture, needle puncture. And again, blood transfusion got the highest risk. We'll see. So 85% actually heterosexual transmission, and other routes of transmission are mother to child, injectable drug abuse, mostly in the China, US, and Russia, and also in the northeastern part of India. We can see this IDU patients, MSM, blood product transfusion, and occupational exposure. These are the major modes of transmission of HIV. This is the percentage. If there is 10,000 exposures, blood transfusion, it will give more than 9,000 people will be affected. For needle sharing, 63, for percutaneous 23, and as you can see that for anal intercourse it is 11, and receptive penile vaginal intercourse it is 8. So this is the global number of HIV infections among healthcare workers attributable to the sharp injuries, and there will be 1,000 cases per year. Actually, it ranges from 2,000 to 5,000. So this is also a considerable amount where the sharp injury is causing HIV to the healthcare workers. So we should always use these standard precautions while doing surgery or any percutaneous procedures in HIV patients. So this is the global distribution of new HIV infections. This big chunk is taken by clients of new sex workers, that is 20%, and actually that is more than the sex workers, 11%. MSM population 23%, transgender 2%, and IDU 9%. Remaining populations 35% are having HIV. So what is important is to diagnose. We should test all the patient at least once. Whenever you feel that there is a possibility of HIV or some immunosuppressed status, test for HIV at least. Unless we test, we don't know what is the status. First, we have to know the status, and then we have to approach accordingly. Few words about pathogenesis. As you all know that our mucosa actually gives a good amount of barrier of resistance for the HIV infections, but the cells capturing this HIV virion are situated in the submucosa. So once it gets inside this mucosa with any breach, any type of breach, the Langerhans cells will take up this virion and then give it to CD4 cells. These are very important cells, and most of the CD4 cells will be going in the resting phase, and some will be activated. And then there will be dissemination of the virus within the lymphoid tissue. The lymphoid tissue anywhere in the body, it could be the gut-associated lymphoid tissue, it could be any peripheral lymph nodes, and they rest there for considerable amount of time, which is called the eclipse phase, when there is no viremia, and then they start replicating and there is immune exhaustion. And that time we get the viremia and we get the infections. So how it persists? Actually, there is a uninhibited proliferation of the virus, and the selection of mutants are there. The more the proliferation, the more the selection of mutants, and our cytotoxic T lymphocytes are actually ineffective. And thus, there is immune exhaust, and there is down regulation of the HLA class 1 molecule also on the infected cell surfaces. Also, there is sequestration of the infected cells into the immunologically privileged site. What are the immunologically privileged site? The CNS and the germinal centers. They are the CTL cell, or the cytotoxic T lymphocyte cells are lesser. So the virus will not be inhibited, and there is persistence of infection. It is the same thing as I already told. There is immune destruction after this proliferation, and immunity is totally lost, and we get the infection persisted. Now we'll discuss about the clinical aspect of HIV. This is a very popular diagram. It is given in every textbook, I think. Once we get the primary infection, this is red color is the CD4 line. The CD4 will be dropped very fast, and then there is mild recovery, and from a long considerable time it will again drop gradually. This green line actually is the viral load or viremia, and the blue line also. There is a sudden rise in the viral load, and then it comes down. So at this phase, it is called the acute HIV or the mononucleosis syndromes. At this point of time, most of the patients neglect what is happening. But the problem is this is the most infectious phase, and here is the highest chance of infections. Gradually, the viral load comes down, and there is an eclipse phase. As I said, it persists in the lymph nodes, and then gradually it disseminates from the persisters, and then there is constitutional symptoms, finally the opportunistic infections and death. So this is the natural history of HIV without therapy. This is the same diagram I told already. So how we classify these HIV cases when it comes to us clinically? CDC actually classifies these as per the CD4 criteria or CD4 percentage, along with some clinical evidence. It is stage 1 if CD4 is more than 500 and there is no AIDS-defining conditions. Again, no AIDS-defining conditions, but the CD4 is 200 to 499, it will be stage 2. Stage 3 will be a documented age-defining conditions. I will tell you what are the documented documentation or what are the age-defining conditions. And the CD4 is less than 200 is stage 3. So these are the stage-defining conditions for HIV. There are a lot of lists, but most of them will be already seeing some esophageal candidiasis, cervical cancer, any kind of cancer that defines the HIV, like Kaposi sarcoma, lymphoma, Burkitt lymphoma especially. These will be taken as the its defining conditions. And opportunistic infections like coccidioidomycosis, cryptococcosis, cryptosporidiosis, CMV infections, Mycobacterium tuberculosis, mostly extrapulmonary, pneumocystis cerevisiae pneumonia, Salmonella septicemia, which is recurrent, and definitely toxoplasma in brain, that is CNS toxoplasmosis. So these are the HIV defining conditions. While who has defined is slightly different way as per the clinical criteria. So I'll ask this question to everybody. In a newly diagnosed PL-HIV with a platelet count of 25,000 without any other alternative etiology for thrombocytopenia, what will be the WHO staging? WHO stage 1, WHO stage 2, WHO stage 3 or 4? Please answer in the chat box. Okay, yes, you are correct. This is a stage 3. Thrombocytopenia, platelet count less than 50,000 will be stage 3. So primary HIV infection can present with asymptomatic or an acute retroviral syndrome, which is a mononucleosis kind of syndrome, where there could be lymphadenopathy, rash, fever, myalgia, looks like common viral infections. Clinical stage 1 will be asymptomatic and there will be persistent generalized lymphadenopathy. Clinical stage 2 has a moderate unexplained weight loss, herpes zoster could be there, and minor mucocutaneous manifestations could be there. Stage 3 actually is very important because clinical stage 3 and 4 we should be very cautious for treating the patient, because if we don't start the therapy, patient may be worsening quickly. But as of now, we have to start ART as early as possible as per the recent guideline. Clinical stage 4 has some HIV age defining conditions like pneumocystis cerevisiae pneumonia, CNS toxoplasmosis, extrapulmonary cryptococcosis, lymphoma, and invasive cervical carcinoma. So we should keep this clinical staging for communicating with other literatures and also for the treatment of the patients. Few words about HIV-2. Actually, it is in mostly in the countries that were formerly colonized with Portugal. In India, less than 1% of the Indian patients, especially in Goa, are having HIV-2. Special thing about HIV-2 is it is slower in progression than HIV-1, and there are fewer opportunistic infections. Patients infected with both the viruses will be having slower progression of the disease compared to those with having only HIV-1 infections. This is the immune response of our body when we get HIV, primary HIV infections. Approximately 10 days, that is 10 days after, there will be rise in the HIV RNA, that is a viremia phase, and maybe 11 to 3 weeks after that, there will be a detectable HIV P24 antigen, which is very important in diagnosing the HIV at an early phase in our 4th generation HIV testing. And then after around 6 weeks or usually after 4 weeks, 4 to 12 weeks, sometimes we get the HIV antibody responses. So this phase, if we test only for antibodies, we may miss this kind of phases. How NACO diagnose HIV? There are 3 tier of tests. First test is most sensitive. So if the test report is negative, there is no HIV, then that is ruled out. But it is positive, then we should give 2 more tests. Okay, A1, suppose A1 and A2. A1 is positive, we should do for A2. If A1, A2 both positive, report is given as then we go for a 3rd test, A3. All 3 are positive, we report as positive. But if any of the A2 or A3 comes negative, then we should reported as indeterminate. If both A2 and A3 are negative, even if A1 is positive, that is most sensitive is positive, but the specific tests are negative, we report it as negative. So I have already discussed this, how to diagnose HIV. We can do HIV ELISA by chemiluminescence immunoassay, or we can do antibody combined with antigen. That is the 4th generation ELISA. Most of the big hospitals are doing this at this time. Or we can do nucleic acid amplification testing for a rapid diagnosis. 2014 European guideline actually asked for a second sample to rule out any mislabeling or confirm any patient identity. WHO guideline also recommends retesting of a newly diagnosed individual prior to initiating ART for that patient. So this is one more question. A person infected with HIV for a long period, more than 10 years, with a CD4 count normal range, plasma viremia remained relatively low, undetectable for several thousand copies. Okay. And he remained also clinically stable over years without receiving ART. So what is it called? Is it a long-term survivor, or is it a long-term non-progressor, or an elite controller, or none of the above? What do you think? More than 10 years of HIV with normal CD4 or controlled CD4 and fairly undetectable viral load, maximum several thousand copies. So what are they called? Yes, answer is right. It is a long-term non-progressor. So what is called a long-term non-progressor? Long-term non-progressor is this kind of people who are having undetectable to several thousand copies, but they remain clinically stable over years without receiving any ART. And 5 to 15% of the HIV infected individuals will fall into this category actually. But long-term survivors are actually not all of them are long-term non-progressors, because patients getting ART in this era of dolutegravir, most of them will be long-term survivors. So these two are not synonymous. What are the elite controllers? They are actually more special group. Only 1% of the HIV infected individuals. Here, the viremia is extremely low, often undetectable, and CD4 counts are normal. So subgroup of that non-progressors will be elite controllers with a undetectable or very low level of viremia. Here what happens? The HIV specific CTLS or the cytotoxic T lymphocyte can clear the infected CD4 cell, and the immune response is actually robust, and that's why the HIV does not progress. Few words about the immune reconstitution inflammatory syndrome. This is a very important aspect we should know, because once giving ART, patient gets the immune reconstitution, there will be all the inflammatory response coming back, and that may confuse with a new opportunistic infection, or it is a immune response to HIV therapy. So there could be paradoxical worsening of the existing clinical condition, or abrupt onset of the new clinical finding, or unmasking. Usually it occurs weeks to months following the initiation of the therapy, and those having CD4 counts less than 50 actually show this iris phenomena more than others, and it can be fatal. So what are the classes of antiretroviral drugs? We all know we have a few more classes also, but for discussion purpose, I will just confine it to these 6 classes: NRTI, NNRTI, protease inhibitors, fusion inhibitors, CCR5 receptor inhibitors, and integrase inhibitors, which is the most important group in this era. So coming to my case 1, there's a 47-year-old male having HIV-1 on ART with lamivudine, abacavir, and nevirapine since last 1 month, develops this kind of rash. As you can see here, some blister-like bullous blister-like lesions all over the body, and there is crusting over the nasal mucosa, and also there is crusting over the lips, and some atypical target kind of lesions over the palm with a CD4 count of 163. So what do you think? What is the diagnosis, and what is the most probable culprit drug in this? Answers, please. So this is probably in the Stevens-Johnson syndrome or toxic epidermal necrosis range. So what could be the most probable culprit drug for this? Patient is on lamivudine, 𝑨𝒂𝒂𝒅𝒏, nevirapine also.
Nevirapine.
Okay, fine. So yes, nevirapine is very notorious for this SJS or Stevens-Johnson syndromes.